Our first talk this afternoon is by Richard Wood, who is the Head of Modelling and Analytics, NHS Bristol, North Somerset and South Gloucestershire CCG, which stands for?
Clinical Commissioning Group.
Thank you very much. Clinical Commissioning Group. Great. So, Richard, over to you.
Thank you very much. And thank you very much for the invite here and for your attendance. I realise this is 1 o'clock. This is around lunchtime after a couple of very interesting talks. So thank you for turning up. I think we're just waiting for the first slide. Whilst that's coming through, as Kate said, I work in the NHS in and around Bristol. So it's Bristol, North Somerset and South Gloucestershire is the area. We're about 1 million people within that geography. And I work at the Clinical Commissioning Group, the CCG. So that's responsible for organising the healthcare for that 1 million population. So working with the various providers, the hospitals, the GPs, etc. In our CCG, we have a dedicated modelling and analytics team that we've had for about 4 years now. So we provide all sorts of math, statistical and analytical approaches to problems in the strategic, operational and tactical domain in the healthcare, for providing healthcare services in our geography. So, right, let me just see if this works. No. I could do it the old-fashioned way with the spacebar. No, that doesn't work either. Let's see if I can move it this way. Okay, there we go. Right, so start with data then. So this is the start of the Bristol Data Week. So I imagine everyone here thinks data is fun and exciting. Yes, a couple of thumbs up. Well, I don't. I disagree, actually. Data is the bane of my life in many ways. It's a constant frustration. So I'll just explain a little bit about that. So first of all, when I think of data, I think about SQL, SQL. So all of the data in the NHS is stored in dozens, maybe hundreds of SQL tables. So the first question, whenever we're doing something, is which table, which fields, where do I find this data? Then we have to write a load of SQL code, which is not at least easy for me. Not very fun. Secondly, then, when we've got that data, wrangling. So essentially what I mean by this is we've got our raw SQL data sets there. We then write a number of different scripts in order to turn that raw data into a calculation data set. So this is the minimum amount of data that we really need, all polished, all ready for analysis with whatever analytical approach we're using on that data. So this can involve merging data sets. So some of those SQL tables will be merging and joining together. We'll be filtering out data we don't need. So at the top there, that's some R code. So we code in my team all exclusively in R, apart from SQL when we have to pull the data out. So filtering data that we don't need, deriving new data fields and variables from the raw fields in those data sets, and various other manipulations to the data. So, for instance, restructuring from the wide data format to the long data format. This is sometimes better for analysis. So this is creating the calculation data set. So again, all of this, in my mind at least, isn't what I regard as fun. Some people do. It's their choice. Anyway, another thing, data quality. Again, another frustration. I don't think this is an exclusive property of NHS data, but the data quality is not always 100%. In fact, a lot of the time it can be a lot less than 100%. So things like missing data here. So we've got a data set here, which is referrals. So we're looking at record level referrals. We've got referral dates. We've got the code of the provider. So that might be a hospital trust. And we've also got the commissioner. So that's a CCG who's commissioned that healthcare activity, that referral, for whatever it may be. So here we can see we've got some missing data in this data set. So this is a problem. We don't get the whole picture when we're doing some analysis on this. There's potential bias. Is it the case that these missing data are from particular groups of people or types of people? Thus, any resulting analysis is going to be negatively affected by that. And also, how do we deal with this in any approaches that we use? Are we going to impute the missing values, so try and fill them in as best as we can, take a bit of guesswork there? Or do we ignore them and just get rid of the rows completely and not be able to make use of any of the other fields where there might be complete data for? Finally, then, is governance. So we've got to do a lot of the work. We've first got to fill out number of forms, more forms, all on DPIAs, data sharing agreements, data protection agreements, and all of this stuff. Completely necessary that we have good governance controls, of course. I'll talk a little bit more about that later. But not exactly what you can regard as fun or exciting, at least in my mind. And as well, here we've got some processes to help try and streamline work, which involve a number of steps. Again, like I say, this isn't exclusive to the NHS, but this is something that, when I think of data, I think of these things and not terribly happy thoughts. But, and just the organisers looking a bit worried, why do we invite this guy saying how rubbish data is? It's all worth it in the end. So we generate a huge amount of insights, useful, actionable insights from the data that we wrangle, that we quality check, that we put together. So I'll just go through a couple of these briefly here. So starting from the top there. So these are some key insights. So following the first wave of COVID-19, we worked out through modelling the waiting list through mental health services that the waiting list for IAPS, which is a type of mental health care, would increase by significant amounts, by 83%, were we not to make any intervention, so any demand or capacity side intervention to that service. We've also looked at A&E attendances during the pandemic, and we found that actually 3/4 of the variance in A&E attendances can be explained just by looking at public mobility, essentially, how people are moving about, how much they're moving about. So we use Google community mobility data filtering down on Bristol, and we just performed simple regression models and made these findings that we could explain a lot of that. That was useful for projecting, for forecasting then, when we can make assumptions about future mobility rates and therefore be able to have a look at what the A&E attendance may be in weeks and months to come. Going around then, third one, so intermediate care capacity should be increased by almost half to optimally reduce acute discharge delays. So what we're talking about here is complex discharge pathways. So patients go into hospital, they have some procedure, and typically older patients and those with comorbidities may require some follow-up care, some continuing care via intermediate care or step-down care services. Now, if that care isn't available, the patient then needs to wait at the hospital. So this is what is referred to as bed blocking, but we refer to it as a delayed transfer of care. Now, in a functioning, efficient healthcare system, you might think that we should be eliminating totally all bed blocking and detox. Fact is, there's variability in length of stay and arrivals, and whenever there's variability, we're never going to be able to do that, because to do so would require huge amounts of downstream capacity in the community setting in order to completely eliminate any chance of blocking. So it's a balance. So we can model this. We can look at the optimal amount by costing up community care and acute bed delays in terms of bed day costs, and we can work out what is the optimal amount of blocking we actually need to sustain in order to optimise costs. And we found during COVID that we need to increase fairly substantially. Moving around then, so we've done some analysis of surveys for virtual outpatient consultations at the beginning of the pandemic. We found that while 35% more people preferred virtual consultations during the pandemic, a good number of those said they would actually like to go back to physical appointments after the pandemic had kind of given way. So that was an interesting finding. We've done some further analysis on this. We've looked also at how effective, as well as patient preference, how effective are virtual consultations in terms of follow-up activity? Do you need duplicative physical appointments after the virtual appointment? And there's a couple of other findings that I'm going to talk in greater detail in some number of case studies that I'm just going to go through. So essentially then, it's not data, at least that's fun and exciting, but it's the use of data. It's what you can do with the data that generates the useful, actionable insights that we need in the health service. So one of the case studies then, just that I'm going to spend a couple of minutes talking about, is casting our minds back right to the start of the pandemic. there was a lot of unknowns. We didn't know from the healthcare provision perspective in acute care how long these patients would be spending in hospital, how many were going to be coming to hospital. This was big decisions around, how many patients we get out of hospital to make way for this surge that we expect. And we saw this as well as we knew bits more and more as we went. We were able to fill in some of the gaps there in terms of the parameters. But the problem essentially is that hospitals need to plan ahead for patient admissions, and as I say, there was a lot of uncertainty. So the solution then is to model future COVID admissions and bed occupancy. Let's just check. Yes, that's working now. Right. So these are some of the outputs from the models. So this is right at the beginning of the basically towards the end actually of the first wave, but at the beginning of the pandemic. So we're looking at spring 2020 here. And what the model is predicting there is the runoff. So we've seen, in terms of daily hospitalizations and bed utilizations, we've passed the peak and we're coming down now. So this is useful for service providers to understand how quickly they can resume elective activity, for instance. In early 2021, we had another interesting predicament here that we used our model for. So what's going to win, mass vaccination or relaxing societal restrictions? Because both were happening at that time. In the first half of 2021, you've got this conflict between mass vaccination, which essentially reduces, would reduce hospitalizations, but then also relaxing societal restrictions, which would weigh the other way. So we, again, modeled this using our model, and these are our projections in early March 2021. And the red squares, can I point here? Yeah. These red crosses here are the actual numbers. So many months in advance, we were able to get fair accuracy based on a number of assumptions we had to make at that time when there was fairly limited knowledge still. So as I say, use of projections is very important for our hospitals, not least, which wards to open. So these guided those kind of decisions, how many beds to prepare, staff rostering, and as I say, whether we need to postpone elective care or how quickly we can resume it. We used compartmental SEIR type modelling for this for all of these projections. I won't go through all of the estimation of the parameters there, but this is a fairly standard modelling approach. We calibrated this for our local system and updated it on a weekly basis. And this gave way to a number of papers as well. So publishing was important for us to get stuff out there for promotion, but also for validation, essentially. So the peer review process affords a kind of verification of the work we're doing. In the NHS, we're always faced with difficult decisions. So we have each year planning guidance where it says prioritise this or prioritise that. We have constraints, of course, fixed budget, and more recently staff shortages. So there's always difficult decisions to be made regarding resource allocation, and we must maximise the value of the resources that we've got. So now turning to another project, which we started towards the end of 2020, recognising that if our ICUs were truly overwhelmed by COVID admissions, we may have to make some difficult decisions around who we admit into intensive care. So this is called triaging. And we know at that time from the data we had that some patients have less chance of survival from ICU, i.e. less chance of benefiting from that resource. They also occupy that resource for longer. So again, it's thinking of things from that resource and what you can get out of it in terms of value. The question then is, could we save more lives or life years by triaging ICU COVID admissions? So we considered a number of different triage strategies here. We looked at a baseline strategy, basically first come, first served, and we looked at various other strategies on how we may go about triaging ICU admissions. We had a model that essentially represented this dynamical process where we've got COVID-19 presentations arriving, requiring intensive care. We've got the ability for intensive care to decline a patient based on some criteria. Or if a patient's admitted, they may be rejected under some of the triage strategies we looked at, and therefore they would have certain survival probabilities there. And of course, we've got the probability that patient who's admitted to intensive care, who is not interrupted, would die in that bed anyway. So we modelled this. We looked at the possible benefits. We found that the greatest benefits, are through the interrupt triage policy. So that essentially means, I've got it written there, this involves reserving the right to prematurely discharge certain patients if an arriving patient more likely to benefit from ICU cannot otherwise be admitted. And if we were to implement this policy, we could reduce life years lost by 12%. So that's our upper bound, really. The question then, ethical perspective, is it fair? Well, you could say, is it fair to deny the opportunity for someone with a high chance of benefiting from that limited resource, ICU, to deny someone that opportunity in favour of continuing potentially futile care to someone who essentially just had the good fortune to arrive first? So that's the ethical dilemma here. It's, again, another difficult decision. Fast forwarding a little bit of time, so early last year, we were looking to, early 2020, December, we approved the Pfizer vaccine for use. I think it was 8th of December, the first person was vaccinated. There was a major exercise called Exercise Panacea in Bristol's Ashton Gate Stadium, which is this stadium just here, on, I think it was the 2nd of December. The expectation was that that site would go live right at the start of January, weeks away. We had to set this up. The question was, for us to begin with, how many can we book? How many people can we book in this site every day? We've got very limited information to go on in terms of this is not a routine thing that has been done in the past. So this was the initial plans when we visited the site. People would enter, they would queue for registration, they would queue again in a small capacity area ahead of clinical assessment. They'd then queue in a 15-space queuing area ahead of vaccination. There'd be 6 immunisers, and then there'd be observation if it was the Pfizer. I think it was the Pfizer vaccine, or was it the AstraZeneca one? I can't remember. Anyway, they were thinking that we could get 1,500-odd people in every day through this process. So we modelled this. We collected actual data from this site with our stopwatch, because this was a live exercise. We fitted distributions to it. We modelled it through a dynamical discrete event simulation model, and we tested various scenarios regarding different booking numbers and configurations of the site. So the results were that daily bookings, 1,500 is way too high. This would result in severe queuing if the site was to go live with that number. The safe maximum is about 1,250 a day. We also found that there's too much post-vaccination observation space. It's not needed. It's not going to be needed. And that actually the vaccination queuing space is too small and risks being exceeded. The impact is that we effected change at the site so that they heeded our advice on the numbers of bookings. This was set at the 1,250 for the opening weeks. The observation space was indeed reduced then to make way for more queuing space, as we suggested. And the site lead commented that it seems to be a good balance struck between maximising throughput and safety, recognising that if we had lots of queues going through where there was a lot of media attention in the opening weeks, this could dissuade patients from vaccination. We also had the Prime Minister. Is he still Prime Minister? I don't know. I haven't checked the news this morning. He was visiting in the first week with a lot of TV cameras and stuff. So we needed to make sure that we had a functioning site. Last case study then. So projecting the recovery of waiting lists. So we're coming all the way through towards the end of the pandemic now. So the question is, how will waiting lists recover post-COVID-19 or post, main big stage of COVID-19? How will this be potentially impacted by different levels of demand and capacity? So our solution then was to dynamically model the waiting list process, accounting for patients leaving the waiting list prior to treatment. So this is going to be happening more. Rich people can go and get private treatment. People will unfortunately die on the waiting list. Their conditions will become inoperable, or they may just prefer not to have the surgery after conservative management. So we accounted for this dynamic in our model. So it's a very simple model, actually. There's a differential equation-based model. We've got all of these forecasts out of the model at specialty level. So this is for our big trust up in the north of Bristol, cardiology, dermatology, etc. This is the past data. This is projections for the next 5 years under different amounts of referral growth, annual referral growth given by the different colours, and capacity growth given by the different line types there. We actually can calculate this on national data that's released publicly every month, and we put those projections that we calculate each month in GitHub. That's for every trust and specialty in the whole of England. We've also looked at the England-wide pan-specialty, pan-hospital trust waiting list, and we modelled this using a more sophisticated simulation model. We made a number of findings. The absolute worst case would be that the waiting list could double if 75%, three-quarters of the 7 million missed referrals during the pandemic came back within the next 12 months. That's the worry, that after the pandemic we'll get a big deluge of patients who didn't go to their GP in the pandemic who now come back. And if through COVID we were only able to provide 90% of the pre-pandemic elective capacity. One of the themes of the event, I believe, is collaboration and working together. So on collaboration, firstly, with other organisations in academia. So we work together with all health and care partners in our system. We also work very closely with Bristol University and other neighbouring universities, collaborating on multi-million-pound applied research grants in recent years. An example here would be the Scenario Review Working Group, where we mobilised quite quickly a very multidisciplinary team, academics, public health intelligence specialists, commissioners, planners, to meet every week to help calibrate the scenarios that underpin the models, that the projections that I showed earlier around the hospital and ICU future forecasts. So that was a definite boon in terms of our collaborative workings there. And also, of course, review the public. So this is your data ultimately. Your data makes all of this happen. As I said earlier, it's anonymized. We've got strict data quality, data information governance controls there. And also your input with regular public involvement, engagement work. And we're always keen to hear your thoughts, opinions on what we're doing and things that we could do. I'll just mention, I'm a little bit pushed for time, system-wide data set. We created this about 3-4 years ago to link together loads of data across our system for the first time at record level. So primary care data we got for the very first time. We linked with secondary care, mental health, etc. We've now got over 80 million discrete patient contact data within this data set. We've got millions and millions of snapshots of patient attributes, demographic records, clinical records, and so on. This enables a great amount of collaborative project work, but it is also itself the product of collaboration. What next for health and care in Bristol? The CCG in less than a month will formally transition to the ICB within the ICS, more acronyms, I'm afraid. But this is good news. It will promote further collaborative work in our area. We'll continue our links with academia to leverage those skills. A final note then, just before I finish, on AI. So I struggle with exactly where AI or machine learning starts and stops and where we get just into applied statistics and analytics and so on. I'd just say that sometimes it's the right tool for the job, but I feel for healthcare organisations more often than not it's not. And we must always ensure we are fitting the model to the problem and not vice versa. So we must choose the right, conceptually appropriate solution for that problem we have in hand. These typically in healthcare seem to be dynamical simulation, time series modelling, mathematical modelling of the kind I presented earlier, classification, predictive modelling, random forest and so on, which I understand some people see that in the AI ML field. Also, from a practical perspective, we've got to learn to walk before we run. So the maturity in healthcare is not such that we can just start rolling out AI on a mass scale. Some people are unfamiliar with regressions and simple things like that, so we need to build things up gradually. Acknowledge computational requirements. We don't have big computers that we can use, so that's a limitation. Also, black box. So if we go back a couple of slides here quickly, this formula here, for instance, if I change one of those input parameters, I know exactly what's going to happen to the output. With a black box type neural network or whatever, there's a limitation there, and customers in our business, in our healthcare organisation, like to know what affects what. So that is, as I think speakers have acknowledged earlier, an issue. Anyway, that's it. Thank you very much for listening.
Thank you very much, Richard. I'm sure there must be questions in the room, but we're pushed for time. So if it's okay, if you do have questions, are you going to be around a bit later? Yeah. Great, then do take up the opportunity. I mean, I found that really fascinating. It's great to have that transparency as well of how the decision-making processes are happening within the NHS and our community. So we're really grateful for you joining us today.